day. Ladies and gentlemen, good morning. I have some conflict of interest. I'm a part-time medical research manager for Hamilton Medical. So, the weaning process depends on the physiology of the patient. Of course, the patient has to be conscious with a good respiratory mechanics, neuromuscular function, hemodynamic state. But unfortunately, it depends also a lot on the organization of the ICU. It's usually a discontinuous process, meaning that we assess the readiness to wean criteria maybe once in the morning, once in the afternoon, but not continuously. It depends on the availability of the caregivers, and sometimes we use very rigid protocols, slow process, like decreasing pressure support 2 by 2 every 12 hours or things like this. And unfortunately also, there is a lot of subjectivity. It's a lot based on experience. Well, according to my experience, this patient will wait another day, or according to emotion, this patient does not look good today, so let's wait tomorrow, and so on. And this is totally independent from the state of the patient. So what are we talking about? Closed-loop modes are modes that regularly or continuously will adapt some ventilator settings according to a physiological variable measured on the patient. And there are 3 modes that are candidates that are dedicated for weaning: Smartcare, adaptive support ventilation, and INTELLIVENT-ASV. Let's keep in mind that we have several kinds of patients in the ICU. First, around 24% of the patients will never enter the weaning process because they will die or they will self-extubate before entering the process. Most of the patients have a short weaning, less than 24 hours. 10% have a difficult weaning from 1 day to 7 days, and a small number of patients have a prolonged weaning. As you know very well, there are several steps during this weaning process. First is the phase of the treatment of acute respiratory failure. Then at some point we decrease or stop sedation and we initiate the weaning. Then we have to screen for the readiness to wean criteria. Then perform a weaning trial, an SBT, and extubate. But as it was mentioned, extubation is not the end of the weaning. There are some post-extubation care which are very important. So first let's speak about the Smartcare. Smartcare is a closed-loop system that is a knowledge-based adjustment of the pressure support, its pressure support modes, to keep the patient respiratory rate in a comfort zone. So how does it work? The physician has to set the predicted body weight if the patient is a COPD, if the patient has neurologic disorder. The ventilator will measure tidal volume and tidal CO2 and the respiratory rate, and classify the patient in some diagnoses. So normal ventilation, hypoventilation, hyperventilation, and so on. And according to the diagnosis, the rule will be to increase, decrease, or keep the pressure support at the same level. So if the patient is fine, this is an example where you will see that according to the time, pressure support will decrease progressively every 10 minutes, for example, to a minimum level that will be considered as an SBT. And if the patient remains a certain time, duration at the minimum level, then you will get a message that the SBT is successful and we should consider extubation. What are the evidence? I look for all the next slide at the total duration of mechanical ventilation. There is one positive study in medical patients showing that using Smartcare we can decrease the duration of mechanical ventilation from 12 to 7.5 days, so quite impressive. There are 2 studies in mixed population of ICU patients with no difference between the 2 groups, and 2 studies in surgical population showing no significant results. However, when we plot all this data together, it seems that it can be Smartcare is associated with a reduction of the ventilation duration. The second mode is called ASV, adaptive support ventilation. It's a physiological-based adjustment of pressure support, so it's also pressure support. In ASV, the user has to set a target minimum volume and the ventilator will determine the target tidal volume according to the Otis principle, which is the minimum water breathing, and the Mead principle, which is the minimum inspiratory pressure. So it's a combination of these two formulas. And then it will determine a target tidal volume, and the ventilator will adjust pressure support to achieve this tidal volume. So if the patient is weak, the pressure support will be high, and when the patient recovers neuromuscular activity, the pressure support will decrease automatically. ASV is available for passive patients, and it's an adaptive pressure control. If the patient starts to breathe spontaneously, it will switch to an adaptive pressure support, and we will have to monitor the actual pressure support, and at some point to perform a weaning trial, but this has to be manually set by the user. By decreasing the target minute volume, we can do a sort of weaning trial with low peak, low pressure support, keeping the patient on this mode. What is the evidence? There are some studies in COPD patients showing a reduction in mechanical ventilation. All of these are randomized controlled trial. One small study in RDS that was not significant, but a very small group, and one trial in medical patients that was statistically significant, but the number were exactly the same. And there are quite a lot of studies in post-cardiac surgery patients. Most of them are positive and some are not. There is one meta-analysis that combined ASV and Smartcare, and they showed that in a mixed population, mixed and medical patient, it seems that using a closed-loop mode can decrease the duration of weaning, and in surgical patients also. Finally, we have another mode which is called INTELLIVENT-ASV. INTELLIVENT-ASV is a full closed-loop control of both ventilation parameters and oxygenation parameters. So in a SPON patient, INTELLIVENT-ASV will look at the patient respiratory rate and adjust the target minute volume in order to change, increase or decrease the pressure support according to the rate. So if the rate is high, it will increase pressure support. If the rate is low, it will decrease pressure support. In the same time, this mode adjusts also the oxygenation parameters. So the user has to set a target SpO2 ranges, and the ventilator will adjust PEEP and FiO2 according to a PEEP FiO2 table. This mode has a quick wean function, which is an automatic weaning protocol that has to be started by the user, and that uses a 3-steps approach. The first step is the ventilator will screen the readiness to wean criteria. So it will screen the oxygenation parameters, FiO2 and PEEP, the pressure support, so the tidal volume and pressure support, and the drive in terms of rapid shallow breathing and the respiratory rate. And during this time, the ventilator will try to reduce pressure support progressively. When all these criteria are fulfilled, it's a sort of observation phase. So we set a certain time with all the criteria fulfilled before jumping to the third phase, which is an automatic weaning trial, where the user can set the parameter and the duration of the weaning trial, and at the end of the weaning trial there will be the message. So this is how it looks. First step, the ventilator screens the readiness to wean criteria, and for the user, you know right away what is the reason not to start SBT. For example, for this patient, it's obvious that it's an oxygenation problem. PEEP is too high, FiO2 is too high, so we can decide how we will manage to improve oxygenation. Then, when all these criteria are fulfilled, there is a counter that says, okay, these criteria are fulfilled for around 30 minutes already, and we set a duration. So usually in my unit we set 30 minutes. So after 30 minutes, you will see that the SBT will start automatically. So we don't have to change the setting, this will be done, and the user decides which PEEP and which pressure support for the SBT. And at the end of the SBT, which is, you have to set it, but usually we use 30 minutes, if the patient remains stable, the SBT will abort, and we will get a mid-stage that we can consider extubation. Right? It does not mean that we have to extubate. It means that the patient was able to stay half an hour with a low PEEP, low pressure support, and acceptable oxygenation. What data do we have? We don't have so much data about this mode. We performed a small randomized control trial where we compared patients in conventional ventilation, volume control, and pressure support with the manual protocol, and INTELLIVENT-ASV in 60 ICU patients expected to be ventilated more than 48 hours. And we didn't find any difference between the two groups, but with quite short duration of ventilation, 5 versus 6 days. And there are some data in post-cardiac surgery. It's not a randomized control trial. They compared some different techniques. With the first column is INTELLIVENT-ASV. The second one is a manual protocolized weaning, and the third column is a standard weaning without protocol. And they show that both automatic weaning and protocolized weaning was associated with a reduction in the ventilation duration as compared to the standard weaning. So to resume, Smartcare has to be activated at some point when the patient is stable in pressure support, and then Smartcare will reduce pressure support, perform weaning trial, and display a message. ASV is a little bit different. ASV will start earlier. As soon as the patient triggers the breath, ASV will decrease pressure support automatically, but the weaning trial will have to be activated by the user. And INTELLIVENT-ASV will start early, such as ASV, as soon as the patient has a spontaneous effort, but will perform the weaning trial and display the message. What can we expect from this mode? Better outcomes? Well, it depends highly on the control group. And this is what we see in the studies. If you have a control group that has 12 days of mechanical ventilation, we have positive results. If we have a control group at 5 to 4 days, it's very difficult to show some benefit. And it's the same in your ICU. If you have a suboptimal protocol because you are very busy in your ICU or you don't have so many resources, then maybe you can decrease a little bit the duration of ventilation. If you are already very efficient with a very clear protocol, then don't expect to decrease too much the duration of mechanical ventilation. However, I strongly believe that using a closed loop mode will improve the organization. Unfortunately, we don't have studies because it's very difficult to do studies to show that we improve organization. But clearly, people that use it report that having a continuous assessment of the readiness to win criteria can be very useful. It's a way to homogenize the process in the ICU. There is much less subjectivity when we use an automatic protocol. It reduces the workload, and the ventilator provides information why the patient is not ready to be weaned. So in terms of decision, it can be very useful. So to conclude, closed-loop ventilation for weaning is available, and there are 3 modes dedicated for this. There are some evidence that it can improve the outcomes, but again, it depends on the control group. And the experience report an improvement in organization. Thank you for your attention.